Good afternoon, everyone. I'm Dr. LUXMI Sharma giving my poster presentation on the topic Neuromyelitis optica. Neuromyelitis optica spectrum disorder, traditionally known as neuromyelitis optica or Devick's disease, is a rare autoimmune, inflammatory, and demyelinating disorder of CNS, which is characterized by attacks of acute optic neuritis and transverse myelitis. Approximately 75% of patients have antibodies against aquaporin 4, a water channel expressed on food processes of the astrocytes. NMO SD consists of standard NMO, Asian optic spinal multiple sclerosis, association of systemic autoimmune diseases, anti-myelin oligodendrocytes glycoprotein, and other neurologic manifestations that may be associated with MRI abnormalities. Clinical signs and symptoms of NMO are similar to those of multiple sclerosis but differentiated by its increased disability related to relapses. Its prevalence is 13.7% among all demyelinating disorders in India, and in southern India is 2.7 per 1 lakh people. In acute illness, considerable recovery achieved with steroids and plasma exchange. Immunosuppressants are helpful in relapse prevention. A middle-aged male presented to the Department of Ophthalmology, SVRR-GGH, having no comorbidities, with the blurring of vision in both eyes, left eye more than right eye, since 10 days with no pain on extraocular movements or double vision. On investigations, on examination, vitals are stable and reduced visual acuity seems in left eye, with counting fingers close to the face. Anterior segment examination revealed left eye RAPD. Color vision showed red desaturation in left eye. Fundus examination revealed both eye temporal pallor of the disc. CBC was within normal limits, and serum NMO antibodies, aquaporin 4 IgG, was strongly positive. MOG antibody status was unknown due to financial concerns of the patient. Visual fields, right eye normal study, and left eye shows constriction of peripheral fields. CSF analysis showed 6 lymphocytes, glucose level 113 mg per dl and protein 31 mg per dl. VEP depicts a prolonged P100 latency of 165 milliseconds in left eye, suggested of left eye anterior optic pathway conduction defect. OCT shows thinning of the retinal nerve fiber layer in the left eye. MRI brain and whole spine was normal, and MRI orbit showed evidence of hyperintense T2 flare signal noted in the optic nerve with abnormal enhancement noted in bilateral retrobulbar portion of the optic nerve, with thickening of the optic nerve noted suggestive of bilateral optic neuritis. So OCT revealed the retinal nerve fiber layer thinning, and VP shows in the left eye prolonged P100 latency. We asked a neurology opinion for this case, and they confirmed the association of bilateral optic neuritis correlated with the above mentioned investigation findings suggestive of neuromyelitis optica. We started treatment for optic neuritis with IV methylprednisolone 1 gram daily for 3 days, followed by oral prednisolone 1 milligram per kg per day daily, and then tapered for 4 days. During the follow-up period of 2 months, visual acuity came to right eye BCVA 6/9 and left eye 6/6. Anterior segment became normal, color vision was normal. He was not cooperative for the visual fields at that time. So on the basis of above investigations and evaluation, diagnosis of NMO was made. Discussion: NMOSD is a severe autoimmune inflammatory disorder of CNS, presenting as a monophasic or relapsing disease that predominantly targets the optic nerve and the spinal cord. Diagnostic criteria for NMSD with the aquaporin 4 IgG requires at least one core clinical characteristic with a positive test for aquaporin 4 IgG using the best available detection method. Diagnostic criteria for NMSD without aquaporin 4 IgG or with unknown aquaporin 4 IgG status requires at least two core clinical characteristics occurring as a result of one or more clinical attacks. It means at least one core clinical characteristic must be optic neuritis, acute myelitis with the LATM, area post-tremor syndrome, or acute myelitis syndrome. Dissemination in the space, fulfillment of additional MRI requirements. In this case, absence of detectable lesion in MRI spine questions the diagnosis of NMOSD. So early diagnosis and prompt management with aggressive immune modulation is indicated. Thank you.